Um, we'll be presenting a little bit about the radiofrequency ablation of facet joints, which is relatively rare procedure. And so already my uh, work is lessened by the previous presenters, and they have already told you about the anatomy, the how to approach a facet joint and all those. This is just extension for more durable effect. As you see, the facet joint injections, when you do for local injections, many a times they recur. Many a times they recur. So this is the recapitulate of the anatomy. Our main target is the medial branch of the dorsal rami, and there is the components from the above and one level up. So this is actually the table showing what we have to do. For the radio frequency ablation is a little bit technically more difficult than a normal diagnostic or normal diagnostic injections or normal block. So we'll discuss in little bit detail about the procedure, although I don't have entire video with me. So if it is a L1-2 level, we have to do the T12, L1, L2, at least one level up. And our target, please, sorry, and our target is the medial branch of the posterior primary ramus. And we have to be very particular about it when we do the radiofrequency ablation, because it's a nearly permanent damage to the nerve. So this is what is already explained, the Scotty dog appearance. This is a diagrammatic representation, and this is the medial branch. This is our target. This is the already explained by my previous speakers, that this is the superior articular process. This is the transverse process in oblique projection. This is the eye of the Scotty dog, and this is the tunnel. This is the most consistent relationship, and we have to target here. So this is the typical appearance in an oblique projection. So you see the Scotty dog appearance. This is the pedicle, which is appearing as eye of the Scotty dog, and this is the area where between the ear and nose. This is the tunnel, which is covered by a mammulo-accessory ligament and forming the tunnel here. So this is a strict AP view, which is outlining this pedicle and the target area. So now you can see the needle here. This is a bit different from the other procedures, where we are targeting the area upper and outer to the pedicle. So these are the normal needles for the radiofrequency ablations. So these are either 22 or 20 GLP, like 22 or 20 GLP needles, and this is the generator. Indications, as already discussed, this is the chronic low back pain, which we can attribute to the facet joint origin, and most common due to degenerative orthopathy. So pain can radiate down up to thigh, in some cases up to ankle as well. So here I want to make a precautionary note that RFA is used for ablation of different areas of the body, including the vertebral body, tumor, soft tissue. All this, please don't confuse them, because they are not the same. We do RFA for the varicose veins. That is completely different procedure than the vertebral body tumor, soft tissue tumor, ablation of the osteoid osteoma. These are the completely different procedure than the ablation of the for the cardiac arrhythmias. So, however, the neural ablations are almost all the same, and the trigeminal neurology are treated in the same fashion what we are doing for the facet joint denervation. So pre-procedure evaluation, as already explained, is the clinical examination, X-ray, CT, we all do. CT is at times more valuable for the facet joint evaluation, as you can see the subchondral sclerosis and the perifacet inflammatory changes and osteophytes well. But for MRI is now standard. We can see the edema and all those. So prior to the RFA, we have to be very clear that the pain originating is due to the facet joint. If it is not due to facet joint, we are going to produce some other nerve defects maybe, and we are inviting complications. So I recommended is ideally one or ideally two or at least one diagnostic facet block prior to RFA to document the effect. The facet may be intra-articular, but peri-articular facet, for facetal nerve block is also works well. The if we are going for the RFA, you can actually during the diagnostic block target the medial nerve, medial branch, and that works. That is more useful. So diagnostic block may be CT or fluoro guided. Most of the people here more comfortable with fluoro, but as a I am an interventional radiologist, so this is all same for me, and I am very frequent with the CT as well. So one thing is that even recommended that even if it's 70 to 80% transient pain relief is there, then we can go ahead with the RFA for the facet joint. Ideally, 2 blocks at least 48 hours apart. Relief, if you want to document properly, then it should be around 4 VAS gradations. At least 48 hours gap between the diagnostic block and RFA till the anesthetic effect goes away. Investigation, like other presenters for other procedures explained, mainly is the coagulation profile, viral serology depending upon the local practice. We have to stop anticoagulants, antiplatelets, and complications like any other procedure, mostly hematoma, localized nerve deficits, and possibility of recurrence. In technique, it's the prone position with all accepted precautions. We take all the 3 views, AP, lateral, as well as the oblique view. AP to initially see the procedure and mainly alignment of the vertebral bodies. Lateral, not to overshoot because the needle should not go beyond the imaginary posterior line of the intervertebral foramen. Then we can additionally cause neuritis or damaged motor nerve damage here. And oblique is anywhere our projection to this to determine the scotida. RFA probe is 20 to 22 G needle, as I explained, with mild gentle curve at the tip. It is internally cooled with active tip of around 10 mm. We only do skin and subcutaneous infiltration. We should not go deep into the muscle or up to the bone, as we might miss the sensory nerve stimulation. Under fluoro, we advance up to the canal, and once we hit the bone, then mildly angulate it to get and slip over the bone to get into the canal. So pre-ablation, we have to do a testing for sensory and motor roots, and that is mandatory. Sensory set at higher power in short pulses should reproduce the pain. It is 50 Hertz, 0.1 to 1 volt. We gradually increase, and if it should reproduce the pain by 0.5 volt. But if it is more than 1 volt, then we have to readjust our needle. And for the then once it is sensory is done, then we go for the motor nerve testing, and it is lower power, 2 Hertz, and we should not get response before 2 volt. We can see multifidus twitching at times, and if motor response comes before that, we have to adjust the needle as well. So once this is done, then we are ready for the ablation. Ablation protocol is always 70 degree for 1 minute at 50 watt, and then a second ablation about 75 degree for 1 minute at 50 watt. To reduce the post-procedure discomfort, we can inject a small amount of local anesthetic through the needle, and then mild compression. 45 to 60 minutes bed rest is recommended. It can be a daycare and OPD based procedure. What we do is a stellate. The needle have a stellate. So with that, we go up to the canal, then took out the stellate and advance the RFA probe, then complete the entire procedure, take the RFA needle out, and inject the local anesthetic if required. So this is our patient. What we she actually came with a left-sided severe low back pain reading towards the thigh up to ankle at times, and she is not able to walk properly. It is only on the left side, but we have done bilateral facet block in this patient. What we did is the perifacet block on the left as well as in the neural transforaminal injection at that time. So this transforaminal injection for that patient actually produced a severe motor defect immediately. We are actually a little bit scared that time, but it recovered well, and she got a good relief for around 3 months. But again, the recurrence of the pain was there, so she came back to us, and this time we decided to do the left-sided RFA. So this is how we initially plan. This is a Scotty dog appearance, you see. And initially we are planning, and this is, we should not progress beyond this point. So we did a L3-4 level. And you see then our needle is here. In AP, it is like this, an upper and outer quadrant. This is followed by L4-5. And to complete, we also did L5-S1 level as well. Followed by, in this patient, we actually did a nerve root injection at L4-5 level as well, L5-S1 level as well. So following that, she got a significant relief for a long duration and then lost to follow. With this, I come to the end of this presentation. We will be happy to take some questions. Thank you.